Close it. You're meant to be here. Good morning, everyone. Go ahead and grab a seat. You're all friends, so you guys can sit in the middle over here.
Yeah, I know. Okay. Yeah. Okay.
Okay, thank you. All right, good morning, everyone. I am Jordan McCain. I am the Director of Implementation for MedicoCx. I see a ton of familiar faces in here, but I don't know a lot of you. This year we doubled our attendees, so we have so many new people. I'm so excited that you're here. A little background on me. I work for a physician-based allergy company that kind of provides medication access and discounts, and as well as education to independent allergists all across the United States. So I pretty much wake up and breathe benefit investigations. Today we're going to go over a little bit of the key components and our primary objectives of doing benefit investigations and how that's going to benefit your patient. So what is a benefit investigation? We ask ourselves, are we getting enough information from what we're pulling from the insurance company? So the difference between a benefit investigation and eligibility is going to be that the eligibility is really what your patient signs up for and becomes effective of, and then your benefits are what those actual details are. This is my favorite. I love putting memes in all of my slides. The real purpose of a benefit investigation, especially for our buy and bill practices, is to reduce the risk to both the practice and to the patient. If we know ahead of time how much something is going to cost, we can prepare our patient as well as prepare the practice. We want to make sure that we are reducing the amount of write-offs that we will have to do for both the practice from a purchasing standpoint and for our patients. If we know how much something is going to cost in the beginning, we can look into programs like copay assistance or PAP programs to help. I'm not pushing any of those buttons. So let's go back here. Yeah, mind of their own over here. Cost transparency is also very important. If we know a medication is going to cost a certain amount, but your patient is coming in and they have a high deductible, we will have to know how to supplement that. If they've already met their deductible and they are just looking for co-insurance, then that's something that we will be able to tell them. Especially important when we're looking at our technical difficulties here. When we're looking at a lot of these new surprise bills, right? We need to let our patients know how much something is going to cost 3 days before the actual service. So what information do we actually need to get a patient's benefits? It's going to be very important that we have access to online portals. Those are going to be incredibly helpful. For instance, something like Availity will save you immense time. I know that when people think benefit investigations, they think, oh, I'm going to sit on the phone forever. I have to go down the line with all of my codes. Portals like Availity, UnitedHealthcareProvider.com, they provide access to a lot of the eligibility information that you're going to need and the benefit investigation information that you're going to need. We want your staff to be prepared prior to making that phone call or looking up whatever the benefit is online. The information that they will need from an insurance standpoint is going to be the member ID number, subscriber ID number. They can be called a couple different things. Group numbers are also important for those employer-based plans. And then there's also a large list of phone numbers that you can have on the back of the insurance card. Making sure that you have the insurance card available to you is very important because it will have the different phone numbers on the back. Provider services, eligibility. Generally, the eligibility phone number is like a completely automated system. So if you're calling that phone number and you can't get through, it's probably the phone number that you're calling. Always look for other ways to kind of navigate through those. Like I'll go through the claims and say, hey, I can't get through the benefit line, or I can't get through the eligibility line, or I'll go directly to the prior authorization line and say, look, your automated system is just not working. I need you to transfer me to an actual person. And then they're very nice about it. We're going to go on to our patient information. So the patient's name, also know who your subscriber is. So your subscriber could be different than your patient, and that's going to be very important. One step ahead of me always. Let's see. Here we go. Of course, date of birth. Some of the insurance companies, as well as the PBMs, are asking for address and phone number as identifiers now. So that's becoming a little bit more difficult. But the good thing is that they're trying to make sure we have the right patient. As many times as we can check off to make sure that we are doing what we're doing for the right patient is good. Patient information that you may still run into: social security numbers. I hate saying it out loud. I don't want to give it to anyone. Luckily, Medicare has gotten away from that with our letters. There we go. But you still have like TRICARE and things like that. So that could be your additional identifier. Provider information is going to be incredibly important because this is where our kind of in-network, out-of-network statuses will come into play. So have your practice name available, your tax ID, your NPI number, address, and things like that. Especially for buy and bill medication, the address is going to be very important because your HIN number is attached to your address, and you cannot deliver medication to an office without a HIN number. So just keep that in mind. Phone and fax. Let's try to keep the phone and fax to a very specific location because I have worked remotely for 5 or 6 years now, and I still get faxes and phone calls from insurance companies on patients that I don't have anymore. So the more we can limit like all of the information going to one place is going to be very good. So we all know the beautiful disclaimer at the beginning of the call that we all sit through. Our code of benefits is not a guarantee of payment. Keep this in mind. I think that a lot of practices think that, oh, if I just get a prior authorization, we're good. Insurance companies review prior authorizations for medical necessity. They don't necessarily check a patient's benefit before they authorize it. So if you have a patient who has an employer-based plan that does not cover a specific medication, but the insurance company will review that because they have a policy for that medication, their job is to review it for medical necessity, review the records, make sure that your patient meets that. but not check the benefits. So you can receive an authorization without actual coverage for that patient. So just make sure that you're doing that benefit investigation first. Getting ahead of me here. Okay, so what questions are we going to ask for our eligibility? This is going to be a little bit different than what we're going to ask for our actual benefits. We want to know what the effective date, but just as important is what is our termination date. Some patients have plans where they pay monthly of their premium. If they do not pay their premium, it will still appear like they have insurance because they have that little grace period. If it terms and you still have eligibility for this patient, they're not going to pay the claim. So just make sure if they have that coming up, we're aware of it, and we can do a benefit investigation prior, or just an eligibility check prior to the patient coming in. We're getting a little bit away from waiting periods and pre-existing condition limitations, but occasionally they do still happen, especially for practices or payers and employers that have started a patient out. In that 90 days where they're waiting for full insurance, they could have emergency services only. That's a good thing for us to let our patients know in case they do run into something, or you're going to have a bill for this first service because you really need to be seen, and then your actual benefits will kick in. So if we can, let's push it to that 90-day where we can take care of you and it's going to be better covered. Another one is our in and out of network. So although a patient has out of network benefits or may have out of network benefits, we need to consider that the cost for the patient is going to be much, much higher than if the patient was going to an in-network preferred provider. The reason that we look into that is because that cost is going to be much higher, they may run out of their copay assistance quicker. And for states that have like copay accumulators and things like that, the patient will be covered for a little while, but that's not applying to their deductible. So they may have a much larger bill at the end because of those out-of-network services. Just double check. Oops, good here. Whoop. Okay. We also want to look into our calendar year versus policy year plans. That will also affect your copay assistance and how it is used. Some of the manufacturers have from the start that they enroll, and then for your next 12 months, or they have from January to December. So we want to keep in mind how that will cover your patient for calendar versus policy year. So now we're going to get into our benefits. Now that we know the patient is eligible, who they can see, when they can see them, we want to get into our benefits that are going to be specific to the services that we are providing. My favorite way to phrase what services it is not describing the service, but actually providing the code. Now, I know that the portals do not do code specific, and if I could just snap my fingers one day, that would be my number one wish. If a genie popped out of a bottle and said, here's your 3 wishes, it's going to be code specific benefits. Using the actual codes versus just saying, I want to give my patient a shot or this medication is going to provide you with much more coverage. We also want to look at if there are any exclusions or unit limitations for this therapy. So when I say exclusions, it's generally going to be for employer-based plans. Your employer is going to provide you with health insurance, but we're only going to cover things under $2,500. So if you get something under $2,500, you're covered, you're fantastic, but anything over, we are going to exclude, especially from the medical plan. Unit limitations are very important as well because they may cover a medication, but maybe they only cover 30 units and your patient needs 60 units. They will pay that claim to the max of 30 units and they will deny the rest of them. So if your patient can only have so many visits per day or only so many injections per day, that's something that we need to be paying attention to. Do we give them the 30 units? Do we supplement out the rest with samples or manufacturer support? We need to know that ahead of time. The financial benefits for the therapy. By providing that code, we're going to be able to say, okay, this code specifically applies to the deductible. This is very important when you're administering medication and you're purchasing the drug and you're doing the administration of it. Do they have a copay for the admin code, or do they have a deductible for the medication code? They can have both. And I think that confuses a lot of practices on what they should be collecting. But that clear transparency to your patient of how much something is going to cost is very important. Since we already have the payer on the phone, it's a good time to inquire about authorizations and everything else that we would be needing. So we've made it through our benefits. We know exactly what to set our patient up for. We can prepare our physicians or our providers to say, okay, we're going to administer this on this day and this on a different day because they're not covered on the same day, or we can only do a max of this. We want to know how we can get that therapy covered. So that's when we would go ahead and ask, does this require prior authorization? If it doesn't require prior authorization, can we do a pre-service review or predetermination? There are many different ways that we can kind of word that to say pre-treatment review, pre-D, clinical review, like will the medical director review this before we administer it? We always want to ask all of those questions so that we can support our patients, have our claims paid, do everything that we need to do in order to reduce the risk to the practice and to the patient. Estimated turnaround times. I hear this all the time. I don't know when I'm supposed to get this back. That is a perfect question to ask during that benefit investigation is, how long is it going to take for the prior authorization to come back to me? How long is it going to take for my claims to come back? If we're not holding the insurance companies accountable, who is? You know, they can pretty much do whatever they want. So that's a really important question for us to ask. Also, where can I locate the medical or pharmacy guidelines for this medication? Who says what my patient has to do to meet clinical criteria? Now, the FDA will put out a medication and say, oh, here are the 3 things that you need to meet for this medication. But the insurance company needs you to meet those 3 things plus whatever they really want. We want you to meet 3 times the medications because there are preferred medications and we want you to trial all of those. So knowing exactly what guidelines are listed for that patient, for that medication, is going to be very helpful for you in reducing the risk and having that transparency. All right, so what else can we do? If our offices are doing our benefit investigations and we're feeling really confident, but maybe we have some stragglers in there that our claims aren't getting paid or our prior authorizations are having trouble, we need to be reaching out to our other resources. Of course, anybody with your Healthcare Advocate Summit team, your NAMAPA team, everybody can help you with those kinds of questions, but hubs are so helpful. They have the enrollment process, they have the benefit investigation process, your prior authorization assistance, your appeal assistance, copay assistance. There's so many resources through the manufacturer themselves that will be able to help you. What if you can't do your own benefit investigations or your own prior authorizations? You just don't have the time. There are tech solutions. A lot of them are here at our exhibitor hall. So reach out to those services. It could be less expensive than paying a full-time person, especially with PTO and all these like sign-on bonuses and everything that we're experiencing right now in this like post-COVID environment. Definitely look into those tech solutions. Another thing that we can do is encourage our patients to advocate for themselves. You know, we see so many patients and there's only one of us, right? And we get overwhelmed. It's very, very simple to kind of pull your patient into it and say, here's everything that we're planning to do for you. Here are all of the codes. Reach out to your insurance company. And those, I don't know if you guys have called the customer service or member services line, they pick up like that because they want those premiums. We sit there on hold for an eternity, but they pick up for their patients. And as long as they have those codes and they say, here's my doctor's MPI, here's what we're planning to do, they're going to provide them with all of that information. So now you have your manufacturer hub BI, right? That's telling you, yes, you can go through pharmacy. Yes, you can buy and bill. Here's how much it's going to cost. Step ahead a little. Here's how much it's going to cost. So that's our one BI, right? We've got our internal BI that our staff did, which is much more information than you would get from a manufacturer BI. But then you have your patient, right? Your patient's confident. We're confident in our staff. We should be confident in our manufacturers. So there is all the support that we need to make sure that our claims are getting paid and that our patients are set, right? Okay, now we can make it to the end. I'm really happy that nobody fell asleep. This is a rough topic, but so we have our 10 minutes left. Does anybody have any questions about benefit investigations? Yes.
So one of the issues with buy and bill is transparency over reimbursement rate fee schedules. What are your recommendations for getting more information on that?
Sure. So price transparency from the payers can be quite difficult to navigate. I would say check your payer contracts. Even though like the pricing is changing with the insurance companies and things like that, there should be an amount that you signed with your payer contracts that tell you how much money you should be getting back from them, whether it be a percentage. Another thing is to utilize those portals. Availity has Anthem fee schedules on it, Aetna fee schedules on it. So just knowing where those schedules are so that you can pull them every quarter is going to be the most important part of actually pulling those every quarter. If you need assistance trying to figure out how to find those, then you can reach out to me on Swapcard or LinkedIn, and I can kind of help you with those payers and where to locate those fee schedules. Anybody else? Yes, ma'am.
I just want to say thanks for that last part in engaging the patient. I know that I, on times, will try to help get an authorization or get something, and it almost as if the practice is hands off. No, we've got this. Well, I've got this too. I mean, I know a little bit about this. So to encourage us to get the patient involved, thank you for saying that.
Absolutely. If we can advocate for them all we want, but it's also we need to put something back on them to say, like, is this what you want? Is this what you want healthcare to be? And if they're like, I just want you guys to take care of it, then we'll take care of it. That's what we're here for. But I know I'm a very non-compliant patient. I don't know about you guys, but also if I'm like, okay, we're gonna put me on this drug, it's going to change my life, whether it's going to be for the good or for the bad, and I need to be prepared. I make lists, I talk to people, I review everything that I can, and I think when it comes to healthcare, a lot of patients are like that, and they want to be more involved. So let's make them more involved. Absolutely. Yes.
I think that's very in this situation because they never stood up for themselves and they never had a voice.
Right.
Giving them a voice.
Everybody has an opinion, right? Everybody. So it's just giving them that little push. They don't know anything about healthcare. That's why we're here. They don't know codes. But if you sat down with somebody and you gave them a list and said, okay, here's what this code's for, here's what this code's for, it takes a little bit more time, but those financial navigators and advisors inside of the offices are absolutely just irreplaceable. Mm-hmm. So I absolutely love learned helplessness. That makes so much sense. Yeah.
Let me ask a question on a manufacturer side. When you do an internal BI, and then you have our hub that's doing BI, you indicated that you get more wealth of information. What's the difference there? Because I know just with our specific drug, we encourage, if it's a Medicare patient or we know that patient's going to need, PAP to go through our hub. But what's that information that you're receiving that we might be missing as a hub that's doing that may make a difference or not make a difference?
And I get it from manufacturers all the time, is how can we make our hubs better? And I think that when you do the enrollment form and you get that benefit investigation back, it's just so limited. It says, okay, yes, they're going to cover this medication, but it didn't tell us whether it was for vials or syringes, or if it was going to be at home, if it was going to be where it was coming from. And so I think that just having all of these additional steps, like in or out of network or effective dates and termination dates, like all of those little things that are going to go into our claims processing is very important. We don't get that from the manufacturer. Anybody else? Wayne, what's up?
Hey, how's it going? Thanks for all the info. Well, what do you do if you get split payment benefits?
Love that question. Happens all the time. We're only as good as the person that we get on the phone, right? None of us are experts in insurance. I wish that I could say that I was, but I am not. Things change constantly, and if I call an insurance company and I get a person on the phone and I don't think they're confident, that's where it's coming from. So if they don't know what question I'm asking and they don't know how to answer it, instead of doing what we would all do and say, I don't know the answer to that, but let me go find it for you, they just provide you with whatever is in front of them. The other day I called Aetna for a benefit investigation and they gave me benefits from like 2019. And I've been doing this so long, so I said, I think you're giving me the wrong information, because that code hasn't required a prior authorization since 2019. I can actually give you the policy where it was rewritten if you would like that. And he did. He went back and he said, wow, thank you so much for that. We've been reading off of a policy that was terminated. And so when we do our benefit investigation with the enrollment and then we get our benefit investigation in the office, that's where we're looking for it. We're looking for that contraindication to say, oh, no, this is not right. And then we just go back to you guys and say, hey, can you do another one? Or we'll do another one until they actually match and we feel more confident about it. Yes.
We ran sometimes when a payer will not talk to a third party. Give me.
Yeah.
Recommendations are kind of what you do.
So for the manufacturer, we can't really do anything. Like they have said, we're a third party, like you guys can't do anything. The internal investigation is going to be the most important. Yeah, there's nothing that we can really get around that. I'm just trying to sign it like a BAA.
I'm just going to ask, where can I find the medical policy guidelines for this therapy online? Maybe that's a way to say to them, you won't tell me, I'm going to look it up.
Yeah. So the only problem with that is like we were saying, like maybe the insurance has a clinical policy on, but it may not be covered under that patient's benefit. So we can locate it, but it may not actually be covered.
Yes, kind of a similar question. Before making that phone call, and you're doing, sort of your internal homework, what kind of things are you going to look out for other than medical policy, maybe the fee schedule? Is there just like other,
So if you're looking into doing maybe buy and bill, I guess is what the question is referring to, my very first step is always going to be fee schedules, because you don't even want to spend the time to do your benefit investigations and things like that if the cost of the medication is going to be less than what the payer is going to pay for, right? So fee schedules are number one. Benefit investigations are number two. Clinical policy guidelines are going to be number three. Yeah, so if you just kind of keep it in that order, then it's really going to set you guys up for success. Okay.
So I'm working in his office and they don't have fee schedules. They're not sure how to obtain them. What's the guidance there?
So I would recommend that they just contact payer contracting and say, where can I find this? If your practices do not have their contracts that they signed when they started, that is they absolutely have to have those, especially for new medications coming out. Those unclassified J codes, like those get paid at a percentage of billed charges. So if your contract states that you're getting 75%, then you need to make sure that you're billing enough to get that 75% to cover plus 3 or 6, whatever you guys are filling that day. You know, if you reach out, I'm not judging. Get your 6%, guys. Yeah, reach out to the payer, ask, how can I locate these? Anthem, available online. Aetna, generally in the actual payer contract. Cigna, you have to write a formal letter. They're like, we're not giving you this information. But yeah, so we can talk about it more on like each step, like how to get those. Any more questions real quick? I got the red flag. Get me out of this joint. All right, guys. Well, thank you so much for coming.